Thank you so much. It's a real pleasure to be here today. And as we discussed earlier on, I think this is such a great initiative to improve the outcomes of patients with these extremely rare diseases. And I think the only way we're really going to move forward is through collaborative work like this. The third thing I'd like to say is thank you for the title. I think this is probably the best title I've had for a presentation. So Beyond Chemotherapy in Cardiac Sarcomas. And I think in contrast to Brian's presentation, this is going to be very philosophical. I'm aware that we're just before lunch, so I'll probably try and skip through a load of slides so that we have more time for discussion. But in many ways, Brian and I were saying the same thing in terms of the importance of recognizing all these different types of sarcomas, the importance of clinical trial participation, and also the importance of understanding the biology and trying to develop biomarkers for these diseases. So I'm so pleased to be in Toronto. That's my usual sort of trip to work. It's awful, so it's nice to be in the snow and the cold weather. So thanks again. Oh, unfortunately, I haven't got as many disclosures as Brian, but I'll work on it. So I thought it'd be good to sort of try and split this into several sections. The first will be a general introduction. An introduction regarding, I suppose, the philosophy that I and my colleagues have at the Royal Marsden in terms of treating these tumours in the metastatic setting. The second will look at beyond chemotherapy in certain histological subtypes in cardiac sarcomas. So as previous speakers have mentioned, common subtypes include angiosarcoma, undifferentiated pleomorphic sarcoma, intimal sarcomas, synovial sarcomas, and leiomyosarcomas, and just share with you some anecdotal and some interesting data on systemic therapy beyond chemotherapy in these diseases. And I suppose the third component is the fact that histological subtype in itself isn't the complete answer to treating these diseases, as Brian has just elegantly shown. And highlighting this with relevance to cardiac sarcomas, last year at the European Sarcoma meeting, there was a presentation of a randomized phase 3 trial in angiosarcomas, which was devised on the basis of very plausible biological rationale, but unfortunately was negative. Of course, there's been a lot of interest in NTRK inhibitors in sarcomas and other solid tumours. I think the frequency of NTRK fusions in sarcomas is very, very low, but in such a challenging group of diseases to treat, this is clearly interesting. And again, following on from Brian, the importance of biomarkers and biology. And then, of course, a conclusion. So, as I say, I'm aware it's before lunch, and I think the discussion is much more important rather than me carrying on talking and everybody just gradually falling asleep. I'll try and skip through some slides. So, I suppose the essence of this is, what is your approach to the treatment of metastatic sarcomas, metastatic cardiac sarcomas, and can we extrapolate that to the localized setting? In rare sarcoma subtypes, I think this is very much down to a philosophical approach to therapy. Very often for subtypes that are resistant to anthracyclines, we would often offer patients participation in phase 1 trials rather than exposing them to the toxicity of those drugs. And this extrapolation in the UK from the metastatic to the localized setting in terms of using non-licensed drugs is challenging because there are severe restrictions to the use of drugs. I suppose in light of the title, there are currently a limited number of systemic therapies with regulatory approval that fit this title of beyond chemotherapy for sarcomas. And I suppose the tyrosine kinase inhibitor, pazopanib, and NTRK inhibitors are examples that can be used in a variety of subtypes. And a number of the other speakers have highlighted the next point, that systemic therapy selection in sarcomas very much relies on an interplay between a number of different factors. So histological subtype, as has been illustrated this morning, but also, as a number of speakers have highlighted, the behavior of a specific sarcoma subtype in the heart is quite different to the behavior of the same subtype in the skin. And of course, we have to factor in things such as age, performance status, and comorbidities. I think in the UK, one of the major things is access to novel therapies. And we're very fortunate at the Royal Marsden that we have a phase 1 unit with a lot of really exciting drugs run by Johan de Bono. And unfortunately, although Brian is working hard on this, we do currently, there aren't as many biomarkers as there should be in terms of treatment selection. And we really don't understand the biology of many of these diseases that well. So the big elephant in the room, I suppose, is undifferentiated pleomorphic sarcoma, which is a very common subtype and a really aggressive and bad disease, regardless of anatomic location. So again, just to sort of briefly go over this, angiosarcoma is the most common subtype, but the other four, they're pleomorphic, intimal, and synovial leiomyosarcoma. So yesterday on my way over, I had a look at the prospective database at the Royal Marsden, and over the last 25 years, angiosarcomas were clearly the most common cardiac tumour that we saw. There were 75 patients. 70 of these had their histology review confirmed at the Royal Marsden. Because of the time period covered here, there were 15 classified as not otherwise specified. But again, all the usual suspects were there. So intimal, undifferentiated pleomorphic, synovial, and leiomyosarcoma, and of course a sort of ragbag of other histological subtypes. But again, to get any sort of real meaningful information, we need to join together. So I've used this slide a lot, and this just reiterates this point regarding anatomic locations. So as you can see, this is a European study of outcomes by soft tissue and bone sarcoma primary anatomic locations. So patients with cutaneous sarcomas have a fantastic survival, and those with cardiac sarcomas right at the bottom of this list. So this is a really bad group of diseases in a bad anatomic location. And again, when I was thinking about this presentation, a number of years ago, we looked at the outcome of patients with sarcomas treated on the phase 1 unit at the Royal Marsden, and looking at this as a whole, the patients were heavily pre-treated, and in this series the median progression-free survival was a really bad 2.1 months, but that doesn't really sort of say anything, because there's such a mixture of different histological subtypes, different trials, different drugs in stages of development, and there were important signals here. So ASPS, or alveolar soft part sarcoma, very rare sarcoma subtype that's essentially resistant to conventional chemotherapy, as I say, our philosophy has been to offer patients with chemo-resistant disease participation in clinical trials, and anti-angiogenic agents have now become, in a way, the standard treatment for alveolar soft part sarcoma. So Ian Judson did a randomized trial in this extremely rare disease based on observations from these phase 1 trials. Another thing that, again, highlighting Brian's point regarding biomarkers, so we treated a number of patients with metastatic Ewing sarcoma in the, 2007 to 2009. So metastatic Ewing sarcoma, invariably fatal, treated them with IGF-1R inhibitors, and we have a number of patients that are still on follow-up 10 years later with metastatic Ewing sarcoma. And interestingly, there's a patient with metastatic chondrosarcoma that was treated on an early PD-1 inhibitor trial, a checkpoint inhibitor trial that derived benefits. So again, I think, just to keep this really clear, I think clinical trial participation is very, very important in rare subtypes, and it's important in terms of finding that signal of activity, but also that you use your head in terms of trying to select the right trial for a particular patient based on their disease and what we know of the biology. So moving on to histological subtypes, as the other speakers have mentioned, there's clearly an emphasis on using different drugs, different combinations of drugs in these different diseases. As Brian mentioned, we should be comparing sarcomas to carcinomas rather than to breast cancer. And I think things are moving forward slowly, but there's clearly much more work that we need to do. So this has been covered, and we all know that angiosarcomas are incredibly aggressive, but also very, very heterogeneous. And the cardiac angiosarcoma patients in the Marsden database, there were 20, they had a very, very poor clinical outcome. As Dr. Ravi mentioned, the frustrating thing about this disease is that it can respond really well to the chemotherapy drugs that we have, but the durability of response is very, very short. One thing that struck me looking at the database, that there were two patients in their 30s with metastatic disease that had multiple lines of systemic therapy within various clinical trials, and one of these patients actually lived for nearly 10 years, and another patient for nearly 5 years with metastatic cardiac angiosarcoma. So what is it that's different about that individual person's tumor, that individual person's physiology? Is there an immune equilibrium there? Is there something that it enables them to live that long with incurable metastatic disease? Again, undifferentiated pleomorphic sarcoma, very heterogeneous. It's one of the more common histological subtypes, very aggressive clinical behavior. And again, essentially systemic therapy has limited efficacy in this subtype. In other cancers, notably in melanoma and lung cancer, checkpoint inhibitors have revolutionized the treatment of those diseases. And in sarcomas, the results so far have been relatively disappointing, but from the SARC phase 2 trial of pembrolizumab, note the 40% response rate in undifferentiated pleomorphic sarcoma. And for pleomorphic sarcomas in that trial, the median progression-free survival, and again, remember this is in the metastatic setting, is about 7 months. So I think there's a signal of activity there and a hint of a promising systemic therapy beyond chemotherapy in this histological subtype. And again, in the Alliance trial, there were responses in undifferentiated pleomorphic sarcoma, angiosarcoma, and leiomyosarcoma, all relevant in terms of treating cardiac sarcomas. So we have an investigator-initiated trial of gemcitabine and pembrolizumab currently running at the Royal Marsden. I'm currently treating a young gentleman in his mid-30s who was diagnosed with a cardiac sarcoma in 2018 and had this sort of belt and braces treatment of surgery, radiation, and chemotherapy, but unfortunately developed metastatic disease fairly rapidly after primary treatment. And we put him on the phase 1 trial. And his first interval imaging on trial has shown a partial response to treatment. So again, opening up the possibility of potentially extrapolating this to the localized disease setting. And another one of the lung metastases. So moving on to intimal sarcoma, as previous speakers have mentioned, this is incredibly rare. So thinking about sarcomas as 1% of adult cancers, this is less than 1% of all sarcomas. And again, the management is challenging, limited to case reports and series. There are some data to suggest that targeting MDM2 is a potential therapeutic avenue in this disease, and there have been anecdotal reports of responses to MDM2 inhibitors on clinical trials. And again, this suggests that this could potentially be extrapolated to the localized disease setting. That would be impossible in the UK, but in the US may be more feasible. And I'll just sort of throw this case out to the audience. So this is a gentleman that I treated a number of years ago, 42-year-old who had a long diagnostic pathway, had a 2-year history of chest pain and shortness of breath, was diagnosed with chronic embolic disease, and in January 2015 had a right pulmonary artery endarterectomy, and essentially the pathology was reported as an intimal sarcoma. So what would be your next step? What would I'll pick on Brian maybe, and what would you do? Positive margins.
And stage the patient.
And assuming that staging is negative.
That's hard.
Yeah, it is hard. So
it's hard. Just because you don't know where to radiate, and I sort of have a philosophy that adjuvant chemotherapy is a curative in the chest outside of synovial. And so I might wait and watch until I knew there was a target to assess response.
So Brian is a true skeptic, according to Dr. Dimitri. So I quite like this. So I think I was at a meeting, or I sent an email to a load of people around the world just to see what they would do. And George Dimitri came back with this philosophy or sort of evidence-based approach to this disease. So you're either a true believer and you go in and do another operation, irradiate the chest regardless, and give a whole load of chemotherapy. Brian is really British, and he is a true skeptic, so I thought that you would choose that one. And I suppose I probably fall into the agnostic but hopeful camp on this, that we try chemotherapy and wouldn't proceed to another operation or radiation. But of course, there's no right or wrong answer to this disease. And again, this really highlights the importance of this meeting in terms of trying to sort of build up an international data set so that we can better advise our patients and develop better management pathways.
Robin, may I ask a quick question?
Yeah, of course. Good. It's better that you ask questions rather than me just talk and talk. And
so, in this particular case, when it was originally diagnosed, what would be the downside of putting this patient on? So, intimal sarcomas actually respond really well to AZA-nifosbamide. So, what would be the downside of starting this patient? You got PET CT as Was that pre-op or post-op?
That was that's a fantastic point, and I'd sort of skipped over this a little bit. Essentially, it was an outside referral, so the patient lived in another country, was referred to another hospital in the UK, and then subsequently referred to the Royal Marsden. But I totally agree. Giving neoadjuvant chemotherapy would have been our preferred option, but it was a done deal by the time he was referred to us.
I would like to point out my answer would have been different had they not already been messily resected.
Yeah. Point fully taken. Point fully taken. So, moving on to synovial. Oh, great, Abba.
Sorry, so what did you end up doing, and how was the patient?
So I'm agnostic but hopeful, but unfortunately the patient developed brain metastases and sadly passed away about a year afterwards. So that's the bottom line. And again, it just highlights that, as you mentioned, these tumours have such a dire prognosis.
So no chemo was given at all, or
no, agnostic, but so try chemotherapy.
so
Yeah.
two kinds of
Yeah.
which is very close to what we would have done as well, and it's really hard to assess these two. Whenever we talked about it a few minutes ago, when you're giving it in the adjuvant setting post resection, you have no idea whether you can't classify them, which is why even if you're thinking about surgery and if your surgeon requires 3 weeks to schedule, might be worthwhile just to get a flavor for what kind of response you might be looking at before operating.
That's why I love this phrase, agnostic but hopeful. It just sums it all up.
But Robin, I think this, since this is going out worldwide, I think this is why the guidelines, at least in the U.S., say should be evaluated by a multidisciplinary team before you get started.
Agreed. And as you know, the in general in the UK, sarcomas are all are referred to sarcoma centres, but this was an international patient that came through a different route of referral, basically. So, but yeah, totally agree with you, Brian. So, moving on to synovial sarcomas, again. These tumours are challenging, can affect the adolescent and young adult age group. They're generally regarded as chemosensitive, whatever that means, particularly to ifosfamide, doxorubicin, and trabectedin. Again, pazopanib may have activity in this this particular histological subtype. But I think one of the interesting things about this disease, following on from Brian's presentation, is the expression of cancer testes antigens, and that these present the opportunity of an immunotherapeutic target in this disease. So particularly NY-ESO-1 and MAGE-A4. At the Fred Hutch in Seattle, Seth Pollock and I did a number of investigator-initiated trials of adoptive T-cell therapy against NY-ESO-1. I would say that we saw some dramatic responses, but the responses were not durable. And last year at the European sarcoma meeting, Brian, in fact, presented a trial of treatment targeting MAGE-A4 with a very good response rate in synovial sarcoma. So again, this raises the question of extrapolating these data from the metastatic setting to the localized disease setting, and how do we go about doing that in such a rare disease? Leiomyosarcoma, again, is a relatively common histological subtype. There are many systemic therapy options for this disease, but there's considerable biological and clinical heterogeneity, both in terms of anatomic variants. So as that previous slide shows, a cardiac leiomyosarcoma has a much worse prognosis than a cutaneous leiomyosarcoma, but there are also clearly molecular subtypes of this disease as well. And again, following on from previous presentations, it's really asked the question, is there a way that we can better select the treatments that are currently available to us within a particular histological subtype? So, as I said, histological subtype not the complete solution without a biomarker and an understanding of the biology. I mentioned that there'd been a randomized phase 3 trial in advanced angiosarcomas, and you can see here from phase 2 trials that the median PFS for systemic therapy in the advanced disease setting is really non-durable, and we need to do much better. So there was a fair bit of promising biology behind the use of an anti-endoglin antibody in advanced angiosarcomas, and in phase 1 and 2 trials there had been durable responses, particularly in cutaneous angiosarcomas, and this led to a randomized phase 3 trial randomizing patients to receive pazopanib alone or pazopanib plus the anti-endoglin antibody with fairly standard eligibility criteria, apart from age greater than 12 years. And patients are stratified as per cutaneous versus non-cutaneous disease, as well as prior chemotherapy, no 1 or 2 lines. And the bottom line is that this trial was negative and showed no difference between the 2 arms of the trial, both in terms of progression-free survival and overall survival. How am I doing for time? Yeah, sure. Well, as I said, there's been a lot of interest in NTRK inhibitors. These are rare, and they're particularly rare in adult sarcomas, I would say. There's some data that have been presented at the CTOS meeting in 2019 and 2018 with very impressive plots of responses. But again, the devil is in the detail here in terms of the individual histological subtypes, particularly in the adult patients here. But of course, as I say, in such challenging diseases to treat, if there is a NTRK fusion, this would be a very interesting concept to use in the localized disease setting. And a dramatic response in a patient with an NTRK fusion treated with an NTRK inhibitor. And then really briefly, just some work that one of our PhD students, Alex Lee, has done with Paul Wang in his lab, looking at potential biomarkers for the use of pazopanib in soft tissue sarcomas. And based on published literature, Alex looked at PDGFR, alpha and FGF R1 expression, P53 status, as well as some gene expression analysis, and came up with a potential biomarker for long-term clinical benefit to pazopanib in soft tissue sarcomas. And to cut a long story short, this has been validated in a cohort of patients outside the Royal Marsden, and has also been assessed in a group of patients that are pazopanib naive, and the classifier is not prognostic in pazopanib naive patients. So I think I better stop, just because everybody's getting a bit tired. So in conclusion, I think there are a number of fairly promising approaches in histological subtypes that occur in the heart. I think the use of checkpoint inhibitors in undifferentiated pleomorphic sarcomas is really interesting, as illustrated by the case that I showed of our patient treated on a phase 1 trial. There may be a role for MDM2 inhibitors in intimal sarcoma, but again, in such an incredibly rare disease, defining that is very challenging. And as Brian has shown, targeting MAGE-A4 in synovial sarcoma is also very promising. Histological subtype by its own is not the complete answer, as shown by the phase 3 trial in angiosarcomas. Tumor agnostic approaches are interesting, so even though NTRK fusions are rare in sarcomas, if a cardiac sarcoma were to harbour one of these fusions, it's definitely worth pursuing that as a therapeutic option. And again, in line with Brian's presentation, we really need to incorporate putative biomarkers into clinical trials so that we better use the therapies that we already have. And, that's one of the things that Paul Huang and I have been working on with that classifier for pazopanib. And I think, again, just to reiterate this point, we need to all work together towards improving outcomes for patients with localized disease, and that's why this meeting is just so important. I'd like to thank all my colleagues at the Royal Marsden, and with that, I've probably really confused everybody, and then just thank you for listening to me before lunch.